So it's my pleasure to introduce the first speaker, Dr. MANUEL CARCAO, who is a pediatric hematologist, oncologist at the Hospital for Sick Children in Toronto, and is also the co-director of the Hemophilia Clinic and a senior associate scientist, clinician, investigator, that's a really long title, in the hospital's Research Institute. His research interests includes congenital bleeding disorders, prophylaxis needs, pharmacokinetics and inhibitor development, childhood ITP, and spherocytosis. He is also the past president of the HCDC from 2006 to 2008, and the immediate past chair of the CPTHN, the Canadian Pediatric Thrombosis and Hemostasis Network. And he's really happy with the title of his presentation. Today you'll see with the slides, I think we chose the title for him, but maybe we'll have to pick another one.
Well, thank you, and good morning to all. I'm just timing myself. Yeah, so when it came to the title, this was the original title that was proposed to me, Extended Half-Life Factors, Do They Make a Difference? I actually suggested that we change the title about a month ago, but then I forgot about it until last night when I noticed that. So the title is now, Do They Make a Difference and Are They Here to Stay? So I did make some adjustments to my presentation to deal with the second part of this presentation. Here are my conflicts of interest. I've worked with many of you in this room, many different companies in many different capacities. So you're going to hear in this session a lot about novel therapies. You're going to hear about extended half-life factors, Emmasysm, rebalancing therapies such as fitusiran, concizumab, and you're going to hear about gene therapy. And of course, all of these things are potentially available in the future, some of which are available now. But you're only being asked the question, do they make a difference when it comes to actually factor concentrates, which is interesting given that we're dealing with a disease where your patients are missing these factors. So you would think that certainly they are going to make a difference. By asking the question, it is almost suggesting that perhaps they don't make a difference and perhaps they won't be here to stay, but I'm going to hopefully persuade you that they do. So for the other things, we don't even ask. Do they make a difference? We simply assume that they do make a difference. And one of the questions is, do they really? At least some of the rebalancing therapies, they're not even here. So it's really unclear if they're going to make a difference. So for hemophilia A, all of these things that I'm showing you here are potentially useful. But of course, for hemophilia B, emicizumab is not a potential product for that. So for hemophilia B, you're not dealing with emicizumab, you're dealing with extended half-life factor 9 or those other possible therapies. So that might affect your decision in terms of is extended half-life going to remain here in the future when the competition is that. I was going to ask you some questions, but it took too long to answer, and I only have 15 minutes, so I'm actually not going to ask you these questions, but there will be a question at the end of this that I will ask you. So I'm going to skip these, and I'm just going to now continue with the presentation. So extended half-life factor 8 products, as you know, there are 4 of them. 3 of them are already licensed. 2 of them are available in many parts of the world. Actually, 3 of them are now available. So as you know, the first one in green over there is an FC fusion factor 8. The other ones are all pegylated factor 8s. They have different amounts of PEG, but they all actually end up extending the half-life of factor 8 by about the same amount, about 1.4 to 1.6-fold more than standard half-life products. When it comes to extended half-life factor 9, there are 3, all of which are licensed, all of which are available in different parts of the world. And in Canada, Alprolix was available, and now Rebenine is mainly available. All of these are different. They have different technologies to prolong the half-life, and they prolong the half-life of factor 9 considerably, as shown here. So in the past, we know that full-dose prophylaxis for severe hemophilia A with standard half-life factor 8 would work. This regimen that I'm showing you there, where every single circle is an infusion of factor, will work and provides very good protection from bleeding. But it's not easy. That's 182 needles per year, every year, for a person's life. And for a child, even one needle is sometimes one needle too much. So this is a very difficult thing. Yet despite that, in our institution in 2016, 70% of our children with severe hemophilia A were on such prophylaxis, receiving factor every other day or 3 times a week. In 2016, extended half-life factors became available in Canada. This was 2 years after they became available in the United States. Initially, Loctate and Alprolix, and then followed by, more recently, Adynovate and Rebenine. We began switching patients at our hospital in 2016, and by 2018, 83% of our severe hemophilia A patients were on extended half-life factor 8. So needless to say, most of our patients are on extended half-life products, and needless to say, we believe on the extra value of these over standard half-life products. So shown here are what the majority of our patients were back in 2016, getting factor every other day, and now in 2019, on extended half-life factor 8. As you can see, most of our patients are on that. So before, 70% of our patients were on every other day therapy, and now 90% of our children are on twice a week therapy or every 3 days. The number of infusions in our patients has dropped from an average of 3.2 infusions per week to an average of 2.1 infusions per week. Needless to say, that is statistically significant drop. And so patients are getting 1.1 less needles, which means 57 less needles per year. Is that significant? Well, that child certainly would agree that that is significant. In addition, the annual bleeding rates that patients are showing, they were low to begin with. They were a median ABR of 1.2, and now it's a median ABR of 1.0. Now, some of you will note that that is not statistically significant, but when you start with such a low ABR, it's really hard to achieve statistical significance. But nevertheless, there is less bleeding, and these patients are getting less needles, so it's really a win-win with extended half-life products. In terms of standard half-life factor 9, if you go back a few years ago, most of our patients were on twice a week. These are patients with severe hemophilia B, and as such, they were getting 104 infusions per year and only achieving factor 9 trough levels of 2 to 4%. Now, they are getting, for the most part, once a week therapy. And I don't know what's happening there, but most of our patients are, as such, getting 52 infusions per year and achieving trough levels, which are significantly higher at 15 to 25%. So do they make a difference? And what do you mean by a difference? Do extended half-life factors get rid of hemophilia? No. Do they get rid of the need for IV infusions? No. Do they reverse established joint damage? No. But no therapy does, by the way, for that one. However, do extended half-life products reduce the number of infusions? Yes. Do they increase trough levels? Yes. Do persons with hemophilia want to switch to these products? Yes. Do persons with hemophilia on extended half-life factor want to switch back to standard half-life factor? Virtually never. So do they make a difference? Yes. But now the second part, are they here to stay? So when you think of extended half-life factor 9, that one's absolutely here to stay. Why? Because there's no competition from emicizumab. The rebalancing therapies may or may not actually get here, and gene therapy is not going to be here for a little while, at least not in children. And until it gets to children, it's not going to have a huge impact. What about extended half-life factor 8? Well, emicizumab is here. So let's think about emicizumab versus factor. So in the next talk, you're going to hear more about emicizumab and similar factor 8 mimetics that other companies are developing. And you will be made to think that this makes a difference. And yes, it certainly makes a difference if you're a young child. But let's just compare the two. So emicizumab can be given subcutaneously and weekly. And we know that it kind of gives you a level of protection that's equivalent to about a 10 to 15% factor 8 level. But that means you still will need occasionally factor 8 IV therapy to treat bleeds. And if a patient undergoes surgery, you certainly will still need a factor 8 therapy. This is, of course, on the use of emicizumab in non-inhibitor patients that I'm talking about. So I'm showing you at the bottom there the regimen. So every Monday you get a subcutaneous injection and you achieve a factor VIII level of 10 to 15%. Now, in the future, with extended half-life products, we know that at least one company is developing a product such as this, which I will call XTEN. And this is a very modified factor VIII that is no longer bound to von Willebrand factor, and as such, you can now extend the half-life of this considerably. This product has been shown to have a half-life of up to 44 hours. Usually in the past, we would talk about extended half-life of standard half-life products having half-lives of about 12 hours. This is now 44 hours. This product can be given weekly as well, but it's given intravenously. With such a product, patients would still have peaks. After a dose of 65 units per kilo, they would achieve factor VIII levels of about 140%. Those would then drop over the course of a week to around 10 to 15, maybe 18% on the study. It showed 18%. This could certainly be used as well to treat bleeds, for surgery. So the level of protection that you have is shown at the bottom with this product. Now let's compare the two. When you compare Emmasysm to that, which would you choose? Choice 1 or choice 2? And here I would like you to vote. The only problem is I'm not sure if I want you to vote with the phones. Should we try with the phones? Okay.
5 minutes.
Oh, we have 5 minutes. We have lots of time. So why don't you vote if you had a choice? And we're going to do 2 votes. One is everybody, and then the second vote is just going to be the patients or the parents of patients. So if you had a choice, Emmasysm or a similar factor VIII mimetic once a week subcutaneously, or an extra extended half-life factor VIII that you can give once a week IV, which of these would you choose? So vote now. Let's look at the test here.
We have to answer all your previous questions first.
Sorry?
We have to answer all your previous questions
There
first,
we
and
go.
then after we
Oh,
get to
you're
your-
kidding.
That's okay.
We good.
Oh, my God.
Finally,
Well, there goes the 5 minutes.
There.
Holy.
that's everyone.
Okay, are we done? So as you can see, people are changing their minds as I'm speaking.
You can see
Oh, I see, there's more people. So it's basically a 50-50. Can we do the vote again, and this time, just the really important people, meaning the patients or the parents of the patients should be voting on this. But I don't know if we can do it a second time. Okay, anyway, why don't we just go on? Thank you. So as you can see here, and I'm showing you this here for factor VIII. For factor IX, of course, there is no Emmasysm. So I think if I was to ask you, is extended half-life factor IX going to continue for the foreseeable future, in the next 10 to 15, 20 years? I would say that the answer to that is yes, because we don't have an alternative in the very near future for the vast majority of patients, even though you're going to hear about gene therapy for adults. But remember, for the first 18 years of your life, you're not an adult, and so it becomes pretty important to have a product that you can use in childhood and not just wait until you're 18 years of age to use it. So clearly, factor IX is going to continue, and I think half of you are saying that extended half-life factor VIII will certainly continue as well. So do extended half-life factors, do they make a difference? Yes. And are they here to stay? I think for sure. Remember, we are dealing with a disease where patients are missing factor VIII, patients are missing factor IX, and there is nothing really still as good as nature and replacing factor VIII and replacing factor IX, particularly if you don't have to do it too frequently, is still probably the best way of managing these patients. And with that, I thank you for your attention.